All right, so the topic is pelvic health. So why is this important, and why is this important for people with Parkinson's? So there are a lot of things that can be going on, and these are just some stats that point that it's very important to have them talk to their providers or bring this up with your patients. So 38 to 71% report overactive bladder symptoms. So I'll discuss that a little bit further. And then constipation is this is the second most common non-motor symptom of PD, which again, I'll explain a little bit later, but these two symptoms might have been around a lot longer than, when the diagnosis was given. There are many other factors to consider when teasing out the cause of pelvic health symptoms. So the stage of Parkinson's, previous history of having babies, if someone is in menopause or not, medication involvement, and then there are a lot of other comorbidities that might be involved as well. So the heart, kidneys, blood pressure, diabetes, all of that can be related, and then just natural age-related changes can play a role in pelvic dysfunction. So this picture right here on the right is showing this view, and then the other picture is showing this view. So in both of these pictures, you can see that there's a lot of muscles that are involved in the pelvic floor, and they attach to the pelvis itself. So they aren't just, there's a lot of different things that the pelvic floor is good for. The internal pelvic floor muscles, which is kind of this hammock, that's more to provide on the side because it shows that the bladder, uterus, and rectum kind of hang out within that hammock. So that shows that you're getting a lot of support from the pelvic floor. All right, so I'm kind of breaking it down with bladder, bowels, and then sexual dysfunction, because everything tends to be involved with persons with Parkinson's. But again, everyone is different. So here I have the brain and then the bladder, and right underneath the bladder, I forgot I had a laser, right there is the pelvic floor. Okay, so with the bladder dysfunction, you can have a brain component, a bladder component, and then the pelvic floor. All of that can be involved. So with the brain, you're getting the signals. Like, I have to go to the bathroom. And then with the bladder, you're getting, the input, the fluid intake from all the things you're drinking throughout the day. And then the bladder itself has a muscle around it. So that can be, a cause for concern as well. And then the pelvic floor. So with people with Parkinson's, the brain is going to be affected, right? So a lot of the times we see urinary urgency or urinary leaking as well. So with urinary urgency, the brain is getting mixed signals from the bladder saying, I have to go, gotta go right now, but that might be only 30 minutes after going to the bathroom. So that's not, the right amount of time to go to the bathroom. The average amount is every 2 to 3 hours. And with that, you then have the bladder. So with that muscle I was talking about, the detrusor muscle, that muscle is very important for the bladder to relax so that you can go to the bathroom. So what can happen with people with Parkinson's, with that rigidity component and the muscles being really tight all over the body, the muscle within the bladder itself can be tight as well. So with a tight muscle, you might have increased signaling or overactivity, telling the bladder itself, like, hey, I have to go, I have to go, I have to go. And then you have the pelvic floor. So with the pelvic floor, more times than none, people with Parkinson's will have a tight pelvic floor. So then you're getting the overactivity and muscle imbalance around the hips. So that makes it harder for someone to relieve themselves of both urine and bowels. So we got the brain, increased signals, bladder, increased signals, and then the tight pelvic floor, which can all be, a big issue for people with Parkinson's. And then with the bladder as well, just thinking about behavioral things that we can change. A lot of people don't drink enough water. And if you're not drinking enough water, your urine's going to be more concentrated, and that is then going to cause more signaling to the bladder as well. So I have a little science experiment over here. Which water bottle is darker? This one, right? So this is about 6 ounces, 6 to 8 ounces, and this is 14 ounces approximately. So that's about how much water your bladder can hold before you have to relieve yourself. So that's a lot more than people think. And it's a lot more clear, so it would be less irritating to your bladder. So a lot of the times what I see is people are having a lot of urgency, but they're stopping drinking water because they think if they stop drinking water, then they're not going to have to go as often. But that can also feed into the problem because their urine's more concentrated. All right, so I touched on most of these, but the common symptoms are urinary urgency, frequency, urinary incontinence, incomplete emptying, and nocturia. So incomplete emptying is when you're not fully emptying your bladder, and that can be because your pelvic floor is tight as well. And then the nocturia, that's nightly frequency. So a lot of people will tell me that they wake up a couple times at night to relieve themselves, or they're having accidents at night. So I'll touch on that a little bit later, but those are most of the things that people come to me about. Why is this important? So with urinary issues, it can lead to high risk of falls. So people are rushing to the bathroom because they have that big urge and they think they're gonna, maybe have an accident, so they might trip on something. Or they're not drinking enough water and not going as frequently as they need to, or not having proper hygiene, and that can then lead to UTIs. And there's one study that showed that UTIs, GI disorders, and falls were the main reasons for hospitalization among people with Parkinson's. So that's big. There are a lot of things that just one session of education can help people with Parkinson's about in order to decrease their risk of falls. All right, so treatment. There are a lot of things. I'll try to touch on a couple of these strategies. I could talk about this for hours, but the first thing I usually have people do is fill out a bladder diary. So that will tell me what they're eating, what they're drinking, how many times they go to the bathroom, and if they're leaking. So that just gives me a little bit of insight into what's going on, and more times than none, most people are not drinking enough water. So that would then be maybe something I'd recommend for diet and fluid. And then diaphragmatic breathing is helpful. I'll touch on that a little bit later. Bladder retraining. So sometimes people are going to the bathroom too often, like I said, every 30 minutes or so, or they're taking 4 or 5 hours to go to the bathroom because they're sitting and not getting up and not thinking about it. So retraining the bladder by doing timed voiding can be helpful as well. And then urge control, cueing strategies, caregiver education. Depending on the stage of PD, sometimes caregivers will have to help a little bit more. Manual therapy, and possibly an internal examination. A lot of the times with the people I see with PD, that's not usually the route that I go, because a lot of the times just the education and behavior changes seem to do the trick. All right, so then I'll talk about bowels. So digestion starts in the mouth, starts with chewing. So people with Parkinson's can sometimes have difficulties chewing and swallowing. Again, think about that motor component of Parkinson's. So if they're having a hard time chewing, then that can make it a little bit harder for things to start moving along the gut. So then it goes, you swallow your food, it goes down into your esophagus and then into your stomach. So sometimes people with Parkinson's might have delayed emptying of the stomach. So that's called gastroparesis. And what that can feel for someone is they can feel full longer throughout the day. And they might not want to eat. And then you would move into the gut, and they're going to have slow motility of the gut. And then you go further down the tract, and you have the pelvic floor. And the pelvic floor, again, like I said, is going to be very, very tight. So it's going to be harder for someone to have a bowel movement. And that can then lead to constipation and abdominal pain. And here I have a Bristol stool chart. So this is just something that can help me see, the consistency of the bowels, but then also to show the patients. This is what we want. We want type 3 or type 4. And a lot of the times, people I see have type 1 or type 2, kind of more of a dehydrated stool, and a lot of that has to do with water intake, and as well as fiber intake. So next slide. I already kind of talked about that. And then why this is important, constipation is a predictor of PD. So we kind of already talked about that. But a lot of people have had it for a really long time. So if they can be seen by a physician and recommended for pelvic health therapy, then they might not have to deal with that one underlying symptom. And then there was a study that also showed that if a higher 6-minute walk test, which is seeing how far you can walk in 6 minutes, the less constipated people with PD are. So that just shows that movement is really important for not just the rest of the body and your muscles with Parkinson's, but also the gut. So one thing we like to say is movement is medicine. So movement is also medicine for the gut. And we want to make sure that people with Parkinson's aren't constipated, because that can also play a role in medication absorption. And a lot of people with Parkinson's are on carbidopa, levodopa, which we want to see the effects of. All right, so a lot of these might look a little similar to the last slide about the treatment, but exercise. Exercise is really, really big, like I said, and then behavior modification. So water and fiber intake, time voiding. So this is a little bit different than time voiding of the bladder. The gut really likes consistency. So sometimes I'll recommend for someone to try to go to the bathroom after breakfast, and usually 30 minutes to an hour after breakfast, because that's when the reflex in your gut starts to move things down. And then diaphragmatic breathing, abdominal massage, toileting equipment, and then referring out if necessary. All right, so here's a chart of different fiber. The recommended amount is 25 grams of fiber, and that's of soluble and insoluble fiber. So soluble fiber includes oatmeal, lentils, beans, flaxseed, things like that. And then insoluble fiber are your whole grains, root vegetables, and fruit. So it's really important to get plenty of fiber. And you need 6 to 8 grams of soluble fiber during the day, and then the rest can be insoluble. So what the soluble fiber does is it creates a gel-like substance around the stool to help it move through. So it actually slows digestion, but then you also pair it with insoluble fiber, which adds bulk to the stool. and helps food pass more quickly. So if you have too much soluble fiber, you're not going to get as much movement, and if you have too much insoluble fiber, you might have too much movement. All right, and then here we have what's called a squatty potty. Has anyone heard of a squatty potty before? Does anyone have a squatty potty? Nice, couple people. So this was actually on Shark Tank. I don't know if anyone knew that. Well, almost everything was started on Shark Tank. But the basic principle of the squatty potty is this angle right here. So we're trying to get your knees above your hips, because that puts your pelvic floor at a better gravitational advantage to be able to relax. So think about back in the day when people would squat to go to the bathroom. They would do that because it's more functional and a lot easier to pass stool. So if you don't already have one, you should get one, or you can just use a step stool. And then this is the abdominal massage. It's called the I Love You massage. So you start down on the left side towards the rectum, and that's the I, and then the L, and the U, and you move in slow circular motions 6 to 8 times a day, and that should help stimulate that reflex as well. All right, and then next, sexual function can be affected with people with Parkinson's. So Avery earlier did a really good job talking about why this is important. So sex is an IADL. So what that means is an ADL is just, going to the bathroom, getting dressed, doing your normal day-to-day, and then an ADL is all the other things you need in order to go about your day. So doing chores around the house, driving, things like that. And it's really important for quality of life, and it's often overlooked by medical professionals. So 76 to 78% of men and women show deterioration in sexual health. This was a study for people with Parkinson's. So that's a big amount. And this is another area that people will tell me, oh yeah, that's actually been going on for a really long time, and I didn't know it was related to the Parkinson's. And a lot of people also think it's because of just natural aging. But regardless, there are a lot of things you can do for that. Oops. So common symptoms that can affect sexual function is fatigue, rigidity, tremors, freezing, impaired sexual coordination, ED, vaginal dryness, lack of climax. All of those can be affected. Sometimes, this is very rare, but with certain PD medications, you can have more of an increased sex drive, so hypersexuality. But then also different things like facial masking and speech can affect sexual function or intimacy, like Avery was talking about, being able to communicate with your partner about what you need and what you want. So with people that I've seen at On With Life, this doesn't tend to be a cause of concern for them as much. They are mainly concerned with the bladder and bowel side of things. But I always address it during sessions, like, hey, is this a goal of yours? Is this something you want to work towards? Treatment would be pretty similar with diaphragmatic breathing, but just talking with the couple and seeing what they need and what they want sex or intimacy to look like. So it might even be talking with the OT to find adaptive equipment like Avery was talking about as well. And then medication management and just reframing what being intimate means. So holding someone's hand, going for a drive, just spending time together, things like that. And then just encouraging them to talk to their provider to see if there's other avenues they want to look at. All right, so in all of the treatment slides, I had diaphragmatic breathing highlighted. So this is a big part of pelvic health because your pelvic floor is a part of this pressure system. So you have your pelvic floor and your diaphragm, and then your deep core muscles. And they work together to help maintain postural support, pressure management, but then also breathing, expelling air. So when you breathe in, everything should drop and lengthen and expand. And when you breathe out, everything should recoil and you should be able to expel air. So we use diaphragmatic breathing as a way to help relax the pelvic floor. So I usually recommend having someone work on diaphragmatic breathing 3 to 5 minutes a day, or while they're on the toilet, because this is something that will, one, they're already in a position where they can have more gravity assistance, but then it's just something we do throughout the day. So a very functional area to practice this. So I'm gonna have everyone move to the edge of their chair with so your sit bones are at the edge of the chair. I'll come over here. And then I'm gonna have you put one hand on your chest and then one hand on your low belly. You guys can close your eyes, it's easier that way. And I want you to breathe in nice and deep. And then breathe out. Which hand moved more? A lot of people would say the top hand. That's pretty typical just from our normal day-to-day lifestyle, being on our phones, being on our computers. What we actually want is that bottom hand to move more. So this time I want you guys to think about breathing in through your nose, like you're smelling the flowers, nice and deep into your belly and back, and then exhale, relax. So we'll do that together. I'll have you breathe in. 1, 2, 3, 4, and then breathe out. 1, 2, 3, 4. Did anyone's change thinking about just sending that breath a little bit lower? So that's what I train a lot of the times, is just trying to relax that pelvic floor. So other cues that can be helpful are, taking a long breath instead of a deep breath. Sometimes when you tell someone to take a deep breath, they just breathe into their belly, which a lot of people also call this belly breathing, but it's more that full 360-degree breath. So this is something anyone can use. All of these tips and tricks today are things not just people with Parkinson's can benefit from. All right. Okay, so I just wanted to go over a couple case studies. There's a couple people I saw this year. I saw, we'll call her Sarah. I saw Sarah a couple months ago. She's 57 and she's been diagnosed with PD for 15 years. So in my mind, I was like, I don't know if this is gonna help much. Like, well, I'll see what I can do. So her subjective report was she had constipation, urinary urgency, urge incontinence, a weak stream, and then strain to have a bowel movement. So those are almost all of the symptoms that I already talked about. So I was thinking, oh man, I don't know. But she also mentioned in her subjective, I am limiting my water intake and working on Kegels to help with all of this. So I stress that because, again, we've already talked about limiting your water intake is not going to be a good thing. It's going to feed into that problem of urgency. So we talked about drinking more water. And then she said, I was working on Kegels. So we were actually working with that diaphragmatic breathing. We were working on reverse Kegels. So the exact opposite of what I wanted her to do. So we talked about that a little bit. And then urge prevention strategies. So I haven't really touched on this, but a lot of the time with urinary urgency, it can be behavioral changes that can help. So again, doing that deep breathing, doing 6 to 8 quick pelvic floor contractions. So this is when I would have someone do a Kegel, is if they're having an urge maybe 30 minutes after they go to the bathroom. They know they didn't drink that much water, they probably don't actually need to go. And then usually that urge goes away because that feeds into an inhibitory reflex and tells your brain that you don't actually have to go to the bathroom. And then busying yourself, like, oh, maybe just go do the dishes or do something else for a little bit and that urge will most likely go away. And if it doesn't go away, tell yourself, hey, I'm going to make it, and slowly walk to the bathroom. Don't go sprinting to the bathroom, because then you're probably going to get yourself in a pickle. Oops. All right, next one. So this gentleman came in after he had a hospital stay due to, I think it was diabetes initially. That was why he went to the hospital, and then he was diagnosed with Parkinson's. So his subjective was constipation, nocturia, he had diabetes, and orthostatic hypotension, which orthostatic hypotension is a drop in blood pressure with changes in position. And he has a history of falls while rushing to the bathroom, urge incontinence, decreased water intake, and then he drank Coke and caffeine regularly. And then he also said that he was prescribed a blood pressure medication, but he didn't know if he wanted to take it. So I highlight that because blood pressure can definitely play a role in bladder as well, bladder health, because you're not going to be getting everything moving through your system as much, and it might not be moving through to your bladder as efficiently. So a lot of the times, especially when people have that orthostatic hypotension, when they lay down at night, everything settles. Just think about gravity. If you're upright, you're fine, but laying down, a lot of people then feel that urge that they have to go to the bathroom. And they might not feel that until a couple hours later. And one thing I recommended for him was to try to, an hour before bed, try to raise his legs just to help everything settle in the bladder, and then go to the bathroom. So that actually helped quite a bit. And then I recommended he take his blood pressure medication that was already recommended by his physicians, because that in turn would help with some of the bladder issues. And then we talked about time voiding, because that also is really important for nightly urine frequency, because if you're not going enough during the day, then when you lay down, you're usually going to have those feelings of needing to go. And with him, we only saw each other twice, and it improved from 3 to 5 times a night to 1 to 2 times a night, which is normal. So everything I talked about, there are a lot of different treatments that a pelvic health therapist can work on, but there are a lot of things that I would refer out for. So I would give brief recommendations of fiber and maybe trying a different probiotic or a different gut supplement. But a lot of the people we see are on a bunch of different medications, and they have a lot of complex dietary restrictions. So I usually recommend, I say, hey, try eating more fiber, try a Mediterranean diet, but I really want you to get a nutritionist on board so that they can really map it out for you. And then a gastroenterologist or urologist would be helpful as well, mental health therapist, sex therapist, and then pelvic health therapist. Big takeaways for providers is just early intervention and trying the conservative management route first. A lot of people are prescribed Miralax or oxybutynin for overactive bladder, Miralax for constipation, but there are a lot of different things that can be done before that can actually be pretty helpful. And if you have medication, you want to make sure you're pairing it with pelvic health therapy. And then if you have Parkinson's, make sure you're talking to your provider, you're drinking water, you're exercising, you're working on that deep breathing, and then definitely buy a squatty potty. Any questions? Yes. Yeah. I'll use my belly. All right, so your gut, your large colon is in the shape of a U. So what you would want to do is start on the left side, on the upper corner, and then you're going to massage in a circular motion down kind of along that pelvic, right until you get to that pelvic bone. And then you come over, so that would be the I. You would come over, and this would be the L. It's kind of an upside down L. And then you would do the same thing along the gut, right underneath the ribs there. And your patient or family member, whatever, they might tell you, oh, I can feel that, because there's usually discomfort or abdominal pain with that, but that just means you're working it out and stimulating that reflex. And then the U comes up and around. So you're gonna start low, come up, and then once you get to that corner, you would finish. So I usually would recommend 6 to 8 times and then see if that helps. Anyone else? So I think I finished a little early, but I bet most of you probably have to go to the bathroom right now, so feel free.
Yep. Thank you.
Yeah.
Lily. Yep. So yes, we are done a little early. The next session is scheduled to start, I think, at 2:20. So you definitely have